Okay, so let's go ahead and get started. Welcome all to the last webinar of the FA Research Flash Talk series. Today's presentation will focus on clinical research. We'll hear from 3 investigators who will discuss their findings regarding heart, bone health, and speech in FA. I'd like to remind you that every speaker has 5 minutes and 1 slide to present their research. After each talk, we will have 5 minutes for questions. All your microphones are muted, but you can ask questions by opening the Q&A box at the bottom of your screen and type in your questions there. We will read them at the end of each talk. I think we can go ahead and get started. Our first speaker today is Chukwunonso Okoli from the VA Medical Center in Albany. Chukwunonso is a research assistant and I believe upcoming grad student with Annie Koppen. She's going to talk about heart proteins in FA. And the title of her talk is Proteomic Approach to Friedreich Cardiomyopathy.
Okay. Hello everyone, my name is Chukwunonso Okoli, and as stated before, I work with Dr. Koppen in the Albany VA Medical Center, and we work with autopsy tissue to determine proteomic differences found in Friedreich ataxia. And the topic of today is the proteomic approach to Friedreich cardiomyopathy. First, a major contributor to a lot of the progress we made starts with Dr. Stephen Pellich over in KaiNexus Biotech, located in Vancouver. His lab performed an antibody microarray which looks at about 874 proteins found in the heart of both control patients and Friedreich ataxia patients. And out of these 874 proteins, we chose about 34 that were found to be significantly different in Friedreich ataxia. And so this first image over on the left shows the control heart proteins. The second one in the middle shows the abundance of proteins in Friedreich ataxia. And the interesting thing is that the superimposed version shows the relative abundance and compares the control proteins to Friedreich ataxia proteins. So red indicates that the protein was found in higher concentrations in Friedreich ataxia patients, whereas blue means it was higher in the control patients. So out of these 34 proteins of interest, we began with desmin and alpha-D-crystalline, namely due to their significance in the contractile apparatus of the heart and the heart's ability to pump blood through the body. We use a technique known as double label immunofluorescence, which essentially allows us to see individual proteins expressed in the tissue. And if you take a look at this figure over here, we have a normal control that shows alpha-D-crystalline in the red, desmin in the green, and the merged images all the way at the rightmost side. The alpha-D-crystalline in normal patients shows a very clear-cut, very organized structure of heart tissue. The intercalated discs are very clear and well-defined. Similar thing for desmin as well as the merged images. But when we take a look at the next panel for Friedreich ataxia, it's much more disorganized, much more chaotic in nature. And according to the antibody microarray, alpha-D-crystalline and desmin were found to be in higher concentrations in Friedreich ataxia, which we believe contributes to this look of disorganization in the heart tissue. And this kind of contributes to the difficulty of the heart to properly contract and properly pump blood throughout the body. So another protein of interest that we looked at was insulin receptor beta. This was chosen due to its relevance to diabetes mellitus, which is found in a significant percent of patients with Friedreich ataxia. The insulin receptor plays a very integral role in the maintenance of glucose in the blood, and while insulin is a standard treatment for diabetes mellitus, it has not been used for non-diabetic Friedreich ataxia patients for the control of heart disease. In addition to controlling blood sugar, it also is very important to the signaling pathway for cell development and survival, which was another reason why we went forward and took a look at this protein. We did another double label immunofluorescence, this time with the insulin receptor beta and actin, which is just another structural protein found in the heart. And when you take a look at the normal for the insulin receptor, instead of being found in the tissue, we found that it was more in those endothelial cells and the capillaries and vessels of the heart. And the same thing goes for in Friedreich ataxia patients. You see it more in the endothelial cells and the capillaries than the actual tissue. But a notable difference was found in the actin, where we see a more intense abundance of actin in Friedreich ataxia, especially around the capillaries and endothelial cells, which once again contributes to the stiffening of the heart and the heart's inability to properly contract and properly pump blood through the body. So some conclusions that we've made was overall proteomics is a very new research approach and we're looking into the pathology of the heart in Friedreich ataxia. We looked at 874 proteins and we found that 34 were significantly upregulated or downregulated by the disease. Alpha-B crystalline, desmin, and insulin receptor beta were the ones that we chose as of right now. And while alpha-B crystalline and desmin were upregulated, their impact in the heart was more mechanical in its dysfunction, whereas insulin receptor beta was more relevant to the impact on diabetes mellitus in Friedreich ataxia patients, namely the switch from sugar to fat as the main substrate for energy production in the heart. In the future, we will plan to look at more proteins from the microarray, and we intend to do more immunohistochemistry and double label immunofluorescence in order to not only confirm the results we've seen in the antibody microarray, but also to confirm the location of where these proteins are and confirm its relative abundance. So thank you so much for attending, and I think this is where we have questions.
Yes, thank you, Chukwunonso. We already have a question. How many hearts were tested? Is there an indication of increasing changes with disease progression? Are any of these changes seen before the onset of cardiomyopathy?
Okay. So for the antibody microarray, they looked at hundreds of samples in the heart. Let me go back. For both the control and Friedreich ataxia patients. And then those, instead of just looking at one sample at a time, it was actually more of a culmination or a homogenization of hundreds of them that were shown. And what was the second part of that question? Could you repeat the second part of the question?
Seems like Liz might have lost her audio, so this is Jen Farmer. I can.
Oh my God, I was muted. Sorry. I'm sorry. Is there an indication of increasing changes with disease progression?
So in our lab, we mainly look at autopsy tissue. So it's hard for us to determine things in terms of progression. So yeah, that's my answer.
And
I don't want to speculate.
There was a third part to that question. Are any changes seen before the onset of cardiomyopathy? Do you have hearts that don't have the cardiomyopathy yet?
I see. Yeah, once again, that's since we're looking at autopsy tissue, so this is after death, after the progression of disease. We don't really have access to that kind of information, but that would be a very interesting alternate path or a path to kind of further flesh out how cardiomyopathy works in Friedreich ataxia.
Okay, next question. We are told that FA is traced to a problem with a single gene. Are higher or lower level of those protein a result of that genetic problem?
Oh, wait, sorry, repeat that last part. I didn't quite.
Is if higher or lower level of these proteins, are they a result of this genetic problem of the mutation in frataxin?
Oh, I see. So as of right now, we believe that this is due to the cascade effect of the due to the genetic issue created by that, that leads to the deficiency in frataxin. We think it's a cascade leading to all these other problems that we see in heart protein. So yeah, as of right now, that's what we believe. And we think that by, it's possible that we could remedy the situation either by introducing more frataxin into the tissue or by finding a way to affect the entire proteome of proteins that are changed due to Friedreich ataxia.
The next question is, do you see the difference between male and female samples?
We do not look at differences between male and female samples. Yeah.
Are AB crystalline and desmin also expressed in skeletal muscle and in particular in the intrafusal fibers of the muscle spindles?
Alpha B crystalline and desmin. I'm actually not sure if they're expressed in other areas outside of heart tissue. And it would be possible that those effects might even travel into skeletal tissue if they are present there as well.
And did you find NFS1, ISCU, ACP, SD11, the iosulfur cluster protein that among the upregulated proteins?
Did we find which one?
The NFS1, ISU, ACP, SD11, the one that formed the complex for with frataxin to assemble iosulfur clusters, are they among the upregulated proteins?
Are they among the upregulated proteins?
Yeah.
I don't, but out of the 34 that we found, well, these are proteins of interest that were upregulated specifically in the heart. And out of those, I do not believe that that was one that we found to be upregulated.
And are there any mitochondrial protein in the 34 hits?
Mitochondrial proteins. I believe there are a few actually that are in there. We haven't gotten to the part of the list yet. We're still kind of making our way down the list of 34 and then possibly opening it up a little bit further to the rest of the 874. But as of right now, we haven't looked at any of those proteins yet. We're still looking at more kinases and proteins along that area.
Do any of these downregulated or upregulated protein have the potential to be used as biomarkers?
Potential to be used as biomarkers. Possibly. It's very likely that they could be used for. It's hard to say only because that even though we see an aggregate of proteins that are found to be lower or higher in Friedreich ataxia, it's still very variable from person to person. So it would be very difficult to kind of use it as a biomarker, I would say.
Okay, time is up for questions. Thank you, Chukwunonso. Our next speaker is Hannah Reece. Hannah works in the Vogel Lab at the University of Melbourne, Australia. She will talk about speech in FA, and the title of her talk is SpeechATAX, a multi-language biofeedback speech treatment for ataxia.
I might have to get you to stop sharing your screen if that's all right, to share mine, I think. There we go, thank you. Let's have a look. Excellent. So yes, hello everybody. My name is Hannah and I'm a speech pathologist and researcher working with Professor Adam Vogel at the University of Melbourne. A little bit about me to start off with. I graduated from my speech pathology degree in 2017, moved to Melbourne and started my role as the SpeechATAX trial coordinator. I have loved being a part of the FARA community over the last few years. I'm a speech pathologist at the FA clinic in Melbourne and also love participating in the FARA events such as Lend Us Some Muscle and Ride Ataxia. There's a picture of me at Ride Ataxia. So thank you very much to FARA for having me today. Speech pathologists are involved in the diagnosis and management of communication and swallowing difficulties across the lifespan. Speech is something that can be affected in FA, and people with FA may have difficulty coordinating the many muscles involved in speech. There may be challenges with breath support, so feeling like you're running out of breath towards the end of a sentence, vocal control, so feeling like you need to, or difficulty controlling your pitch and your volume of speech, articulation, so the movement of our lips, tongue and mouth to produce sounds, or prosody, the way that all these aspects of our speech come together to produce a nice timing and rhythm of speech. All of these aspects or challenges in any or all of these aspects may lead to difficulty being understood or a reduced intelligibility of speech. Currently, there are no evidence-based treatments for speech in FA. However, SpeechATAX is looking to change this. The SpeechATAX trial is a therapy being run through the University of Melbourne. The aim of the trial is to not only explore the feasibility of a home-based speech therapy across multiple sites and multiple languages, but to improve overall intelligibility of speech in people with FA from pre-treatment to post-treatment as rated by expert clinicians. There are 4 sites involved in this trial. We have Tübingen in Germany, Auckland, New Zealand, and Melbourne and Brisbane in Australia. Our first participant was recruited in May 2018, and we're finishing up with recruitment in September of this year. We were aiming for 50 people with FA across the 4 sites, and we're actually looking to exceed this number now, which is fantastic. So, what is SpeechATAX? SpeechATAX is a home-based speech therapy designed specifically for hereditary ataxia. It is based on the principles of neuroplasticity and motor learning, including high intensity and high frequency repetition. Participants complete the therapy 5 times per week for 4 weeks on a Samsung Galaxy tablet. And one of the great things is you can choose what time of day you complete the therapy or what day of the week. So it's really flexible for your schedule. You don't have to tee up a time with the speech pathologist, and you can do it from the comfort of your own home, which is really ideal for situations like this. The exercises are designed to improve those things we were talking about before, so vocal control, prosody, and overall intelligibility of speech. They include things like saying for as long as you can, for controlling your pitch and your volume variation, and also practicing over-enunciation of speech or really clear speech. We do this through a range of speech, reading, and question activities that the participant completes each day. SpeechATAX also uses 3 biofeedback mechanisms to enable participants to monitor their own speech in real time. First, we have a feedback bar. This provides real-time feedback of the stability of your voice. We have a replay function that enables participants to listen back to their speech from the day before. We encourage you to have a think about what you did well and what you would like to work on for the next day of therapy. And we also have graphs that compare your performance on a task from today to yesterday in terms of duration, volume variation, and pitch variation. The feedback mechanisms allow participants to monitor their speech in real time and independently. We also have the recordings uploaded to a platform, so we as the clinician can provide feedback to the participants weekly. So, does SpeechATAX work? While we haven't done any formal analysis on this data as yet, a smaller 20-person pilot study was completed at the Melbourne and Tübingen sites a few years ago, and there was statistically significant improvement in that overall intelligibility of speech from pre-treatment to post-treatment, even in mild dysarthria. So that's really exciting, and hopefully the same for this study. So what's next? We'll be working with a statistician to analyse the data and work towards publication of results towards the end of this year. The feedback, importantly, the feedback that I've received from participants so far has been overwhelmingly positive, with people feeling more confident in their speech, feeling like they're being able to be understood more easily, and also pretty much everyone has said they'd complete the therapy again, which I think is a big bonus. So pending positive results, we are looking to create a SpeechATAX 2.0, taking into account people's feedback from this study. So we're making it more user-friendly, a little bit more fun, and potentially looking to expand to other clinical populations and children. In summary, SpeechATAX has the potential to inform clinical care in speech pathology in ataxia globally. So a huge thank you to Farah for funding the project, to Adam Vogel for trusting me with his baby, and to all the participants who have been a part of SpeechATAX so far. Thank you.
Thank you, Hannah. Okay, we have a first question. Is it known if mouse models of FA recapitulate the difficulty in speech, loss of vocalization, and swallowing phenotype?
Oh, that's very interesting. I actually don't know too much about mouse models and speech, so I can't answer that question at the moment, but I will definitely look into it because that is very interesting. I'm not actually sure about that.
I have a question for you. Is there you think there's a contribution of the hearing problems that the patient experienced to the speech problems?
That's a really good question. We, as part of the initial assessment, we do a hearing test as well as a speech in noise test. So difficulty with hearing in background noise is definitely very common in FA. So that might have an impact on our results. We're not sure at the moment, but we thought it was good to definitely test the hearing as well. But hopefully with listening back as well, everyone has reported that that was really useful, a little bit confronting at times, but that it did help with, you know, being more aware of how they were sounding.
Is there a placebo effect related to just getting people to use your interface?
Ooh, placebo effect of using the interface. We do have a, it is a randomized control trial design with a monitoring period. So one group has 2 months monitoring, the other group only has 1, but that's probably not going to account for a placebo effect. That's just comparing to no therapy versus the therapy. From my own observations, people who have gotten the most out of SpeechATAX, just as like a clinician, what I've noticed would be the people who are more motivated and are feeling like, you know, I really want to improve my speech. So they, I think, are the ones who have had improvements and who have noted improvements are the ones who are really motivated.
Can I ask my therapist to use this therapy?
Good question. So we are hoping to work towards making this available universally. At the moment, we are not so much distributing it out to other people. If you would like to, you know, send me an email about some information, we can have a look at that as well. But for now, it is mostly just being used in the trial capacity. Hopefully.
Yes. Do you think there's an additional benefit in initiating this treatment, this training early in the disease, very early in the disease?
That is another really good question. I think that as with all like the principles of neuroplasticity, like the earlier you start a treatment, the earlier you start therapy, whether that's physio, occupational therapy, it is earlier the better. So I would say that speech, yes, the earlier you can come and do a therapy like that, implement the strategies, I think it would be more beneficial. We do have a range of participants involved. We didn't have an inclusionary or exclusionary criteria based on severity of speech. So we have some people whose speech is very mildly affected and some people whose speech is more severely affected. So it'll be interesting to see if there's much of a split there as well.
Is there a connection between speech and swallowing abilities with FA? And if so, have you looked at improvements with swallowing with improvements in speech?
That is another really good question. So being the same muscle groups, you would think that there definitely is a link between speech and swallowing. So in terms of, we're not actually using swallowing as a kind of outcome measure or anything like that, but I have had a couple of people report changes in their swallowing after doing the therapy, which is interesting. So that might be something worth looking at in the future. And I think that Adam Vogel and his team are thinking about looking at a swallowing therapy in FA as well. One of the exercises, the pitch glide, so going from a low sound to a high sound, that's similar to some swallowing therapies. So yeah, it would be interesting to see if it does improve swallowing and how much.
And do you think e-stim might be beneficial for the FA population? And if so, have you explored integrating e-stimulation into the study?
We have not explored e-stim. I don't think that Adam's lab's actually done any e-stim with speech as yet, but there are studies that I've looked into that use e-stim and some other either speech or swallowing techniques. So it would be interesting to see if that as an additional mechanism of the trial would be interesting. I think that one thing that is good about SpeechATAX is that it's a tablet and or it's done on a tablet, so a Samsung or an iPad, which is really available in the home. So you'd have to look at eStim and its availability in home as well. So we'll sort of, yeah, that's an interesting point. These are all really good questions.
Okay, thank you, Hannah.
Thank you.
Our next speaker is Jaclyn Tamaroff. Jaclyn is an MD and works with Shanna McCormack at Children's Hospital of Philadelphia. And she's going to introduce to us a survey on bone health in Friedreich's ataxia.
Yes. Hi, I am Jaclyn Tamaroff, and I am a pediatric endocrinology fellow at Children's Hospital of Philadelphia. And this survey on bone health in FA is something I'm working on with Julia Dunn, an undergrad student at the University of Pennsylvania, along with the FA team at CHOP. And so why endocrine in FA? As many of you know, diabetes is certainly a concern in FA in about 10% of patients, but there's also some concerns about growth and short stature, as well as broken bones, poor bone health, and low bone mineral density, which is what we're going to be talking about today. So why is bone health important? So low bone mineral density can lead to osteoporosis, which can cause broken bones, pain associated with that, decreased function or decreased ability to walk, as well as many other health problems. And there are many risk factors for low bone health in FA, including decreased walking or weight-bearing activity, the use of systemic steroids or glucocorticoids, which are not often used, but sometimes are in FA. Diabetes is a risk factor, and then any chronic illness is a risk factor. So we know that there's these risk factors for low bone health in FA, and we know from anecdotes and from clinical experience that fragility fractures are seen in practice. So fragility fractures are fractures or broken bones of the major long bones in the body, so the thigh bone, the spine, and the hip, that happen from something low impact. So for example, if you fall from standing and break your hip or spine, that would be a fragility fracture. So there are not many studies in bone health in FA, but one that was done by Eichenler et al. In 2014 in a European group looked at a group of 28 participants with an average age of about 38 years and mean FA duration of about 17 years. And almost half these participants used wheelchairs most of the time. And they noted that a fifth of them had low bone mineral density. And this was noted by using a DEXA scan, which is basically a big X-ray that looks at different body parts, particularly the hip, spine, and forearm, and then calculates the density of the bone. So you can see this is a piece of the femur or thigh to hip, and compares it to averages for age and gender. And so about 20% had low bone mineral density for age, meaning they'd fall below this line. And while this isn't the exact definition for osteoporosis used in older patients, those over 50 or 60, many of these patients would have met criteria for osteoporosis and therefore met criteria for management of their low bone mineral density. We also looked at which clinical trials that reported falls and fracture percents in their adverse events, and we found 8 studies that noted the percent of participants reporting falls to be between 7 and 30%, and then the frequency of fractures was about 1 to 5%. So while this doesn't seem like a high percentage, some of these studies were only 2 or 3 months long, and so that is a lot of people having broken bones. And in addition, some of the fractures noted were those pathologic or fragility fractures, such as the pelvis or hip, femur or thigh, and spine. And so unless these were from something really high impact, that is concerning. Julia Dunn, the student working with me, helped me with that, along with looking at a random sample of participants in FACOMS. And in that random sample with participants of an average age of 20 years, at least 25% of them noted at least one fracture. And so again, this is just sort of adding to the fact that fractures are definitely a concern. These DEXA scans, which can be used in research or clinically, were only done in 2 out of 48 of those participants, which makes sense because DEXA scans are not currently part of the clinical management guidelines in FA. So where does that lead us? Well, that's where you come in. What we're planning to do is send out a survey, initially as a pilot to those in FACOMS at CHOP, where we will ask questions about fractures, bone health, any DEXA scans, to try and get additional information about the current management, current screening, and the burden of fractures in FA. Additionally, because we're endocrinologists, we are also going to do some studies, some surveys on diabetes that will be added to these surveys, that those with diabetes can fill out the additional surveys. Our future plan is to expand these to all participants in FACOMS to get a better sense of fracture burden in FA, along with doing some more DEXA studies so that we can better give screening and management guidelines about bone health and how to protect bone health in FA. So I would like to thank FARA for their support, along with all of the patients and their families, and the team at CHOP, including Dr. Lynch and Dr. McCormick. And I'm ready to take questions.
Thank you, Jaclyn. Okay, we have already one question. Have you developed any observation of insights into the possibility of low bone health in FA carriers?
So, sorry, I can't see the questions. So in FA carriers, as far as I know, there are no studies looking at bone health in FA carriers. I think, unfortunately, there's limited insight even in FA about the concerns for bone health, and so that will sort of be the first step.
In that study that you showed, is there a correlation with being wheelchair bound or with the weight of the participants?
So
the other ataxia?
Yeah, so there were correlations in some of the bone health measures in the bone mineral density scores that compared to SARA score, which they used instead of FARS score, and compared to GAA repeat length. The wheelchair use, my understanding from reading the study is that they didn't find a clear correlation with most of the bone health parameters that they looked at, but many of the participants were using wheelchairs most of the time. And so that's one of the criticisms of the study, is that it doesn't really give us any insight into, are the issues with bone health mostly related to using a wheelchair most of the time, or are there issues before people get to that point? And so that is one of the major reasons that more studies are needed.
Yeah, there's another question that's a similar question. It asks about other risk factors, for example, diabetes, if there's a correlation with that.
Not that was mentioned in that study. 28 participants would have been a fairly small number for them to find something significant. I believe, I want to say 4 patients in the study had diabetes. A few did, but I don't think that they did any statistics with that.
And how does this affect scoliosis?
So That's a great question. And most of the participants in that Eichler study did have scoliosis, somewhere in the 60% range. Certainly, if you've already had surgeries, then making sure that your bone health is optimized is really important. But I don't know if there's any correlation with scoliosis per se. Again, just there haven't been enough, so there isn't enough data at this point.
Do symptoms of FA cause shorter height?
So that's a great question. Shorter height and poor growth is something that Dr. McCormick, who's my research mentor, is looking into and sort of thinking about, because there is some concern that FA is associated with shorter height or poor growth. Unfortunately, as many people know, getting accurate heights in the clinic is always a challenge, especially if you are typically using a wheelchair. It may not be something that people are often inclined to do. And so I don't think that we can say that definitively yet, but it is something our group is thinking about.
Are there changes in circulating minerals, for example, calcium, which can affect bone health in FA?
So calcium levels and vitamin D levels are certainly important to think about to optimize bone health. As far as we know right now, there's no specific changes in calcium levels in FA that would affect bone health. But again, there's really, as far as I could find, only this one study that has sort of started to look at bone health in FA.
And are there things we should be doing or taking to maintain or improve bone health?
So that's a great question, and certainly something to discuss with your FA team and your primary providers. I think talking about things like making sure that you're getting adequate calcium intake and making sure that you're getting adequate vitamin D are two certainly sort of easy and important things to discuss with your primary team and with your FA team. Additionally, one of the main things that people can do for their bone health is weight-bearing exercise. So talking to your team about safe weight-bearing exercise that you're able to do is something that could be really important. Right now, the clinical practice guidelines in FA do not have any specific bone health recommendations. And so there's nothing I can say that you should be routinely doing, but definitely talking to your team about calcium, vitamin D, and safe exercise are all important things to do.
And do you include children in your study? Do you think the incidence of fractures in children would be different?
So that's a great question. This survey is intended for children, adolescents, and adults, and it will give you the option to fill it out as a parent, caregiver, or patient. It's right now, the knowledge that we have, certainly we know that using a wheelchair most of the time can affect bone health. And so children who maybe are earlier in their course of disease or are less affected may not have that as a risk factor and may not yet have diabetes as a risk factor. But we do think that there are probably some other risk factors sort of on their own that affect bone health. And so we do wonder if children are also affected. There haven't been any published studies looking at DEXA scans specifically in children. So there's no way to know that at this point, but certainly it's something we would consider if a child came in with what we would consider a fragility fracture. And it's certainly something we will definitely consider in future studies. And that's why this survey data will be really important, because it will help us get a better sense of if these fractures are occurring in children, in adolescents, in adults only. And there are standardized DEXAs that can be done for children as well, if that is indicated.
Okay, thank you, Jaclyn.
Thank you so much.
And let's see. There it is. And thank you to all today's speakers, and thank you for all the speakers of the webinar series. We are grateful to them for sharing their research, for compacting everything in 5 minutes, for introducing themselves to our FA community, and most importantly for their work in trying to understand and cure FA. We would also like to thank all the attendees. We've had an incredible participation from scientists, patients, patient families. I think we've had between 60 and 70 attendees in each webinar. And I think this experience could definitely go in the good things that happen because of COVID-19 column. I'd like to remind you that all the webinars are available on YouTube, and the links have been shared or will be shared in our newsletters. Also, thanks to Jen Farmer for conceiving the idea, Felicia for setting up the webinars, and the rest of the FAIR team. This was a wonderful way of celebrating FA Awareness Month. Thank you all for making it possible with us. This concludes our series, and have a great evening or morning or afternoon, wherever you are.
Thank you.
Good job, guys.
Good job, everyone.
Good job, everybody.